Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show, bringing you another really fascinating guest today, helping to create a better tomorrow on many different fronts. Today we have the honor of being joined by Dr. Elizabeth Fowler, who is currently Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation at the Centers for Medicare and Medicaid Services, which is a federal agency within the United States Department of Health and Human Services that administers the Medicare program, works in partnerships with state governments to administer Medicaid, as well as the Children's Health Insurance Program known as CHIP, and health insurance portability standards. Dr. Fowler has over 25 years of experience in both health policy and health services research. She has previously served as Executive Vice President of Programs at the Commonwealth Fund, Vice President for Global Health Policy at Johnson & Johnson, where she focused on healthcare delivery system and payment reforms in the U.S. and healthcare system and reform in emerging markets. She also served as Special Assistant to President Obama on healthcare and economic policy at the National Economic Council. From 2008 to 2010, she was Chief Health Counsel to the Senate Finance Committee Chair, Senator Max Baucus, where she played a critical role in the development of the Senate version of the Affordable Care Act. She also played a key role in drafting the 2003 Medicare Prescription Drug Improvement and Modernization Act. She's also served as Vice President of Public Policy and External Affairs for WellPoint, now part of the Anthem Group, as an attorney with the Washington law firm of Hogan and Hartson, and 5 years as a health services researcher with Park Nicollet Foundation in Minnesota. Dr. Fowler earned her bachelor's degree here in Philadelphia, University of Pennsylvania, where she studied the history and philosophy of science and technology. She got a PhD from Johns Hopkins Bloomberg School of Public Health, where her research focused on risk adjustment. And she's also has a law degree from the University of Minnesota. Dr. Fowler is admitted to the bar in Maryland, District of Columbia, and the U.S. Supreme Court, and is a fellow of the inaugural class of the Aspen Health Innovators Fellowship and member of the Aspen Global Leadership Network. And we are glad to have her with us today. Dr. Elizabeth Fowler, thank you so much for taking time out of your schedule to come talk to us a little while.
Well, thanks for having me, Ira. I'm really happy to be here and happy to have this conversation.
Yeah, it's a very exciting one. You know, as I reading through your bio, it's quite amazing. You know, your academic interests spanning from science and tech history and philosophy, public health, law. You spent time in think tanks and big pharma, in government, of course. How did it all start out? Give us a little bit of the background to Dr. Liz Fowler, if you will.
Sure, happy to. I was as an undergrad, I thought I wanted to be a doctor. My dad was a doctor. My grandfather was a doctor. My grandfather chaired the internal medicine department at the University of Iowa. And I always thought that my career was going to be a primary care physician. And then I got to Penn, University of Pennsylvania, and took a class on healthcare systems and learned that the U.S. was the only developed country in the world without a national health system, and decided I wanted to do that instead. So I did an internship at the National Health Service in England, and a brief foray learning about the German health system, working for one of their sickness funds, and really just decided that that was so interesting and compelling. And as you noted, I enjoy going to school and learning things. So for me, what's driven me over my career is as long as something is interesting and I'm learning and feeling like I'm, you know, adding to progress, then I'm happy.
Awesome. organization, the CMMI, or the Center for Medicare and Medicaid Innovation, it was created back in 2010, part of the Patient Protection Affordable Care Act. Ultimately, the goal of testing innovative payment and delivery system models that show important promise for maintaining or improving the quality of care in Medicare, Medicaid, and the CHIP program, ultimately slowing the rate of growth. Well, obviously for our U.S. audience, but also for our international audience, I just wanted to sort of start off with some of these numbers because they're fascinating. So we have sort of the $4 trillion or so that we're now spending on healthcare in the United States. Medicare, about $830 billion of that. Medicaid, about $675 billion. Very large numbers. Hence why we, in the case of experts like you, why we need to innovate not just new drugs or devices, but we need to innovate at whole model levels. Talk a little bit, if you would, about what happened back in 2010 as this was all set up, and a little bit of sort of where the directives initially come from. We'll get into some of the different models in a bit, but sort of where the decisions are: diabetes, kidney disease, payment models, how it all works together, and how sort of the directives get to you to lead it all.
Sure. Well, in a nutshell, the rationale behind creating the Innovation Center, and I was working on the legislation in the U.S. Senate back then, while we were debating the Affordable Care Act, there were a lot of people that were, of course, many people interested in finding ways to cover the uninsured and expand health coverage. But there were just as many people interested in finding ways of making care more affordable and the public programs more sustainable. So how do you bend the cost curve of health spending in the US? And we looked for policies that would do that. We talked to academics, we talked to the Medicare Payment Advisory Commission, we talked to experts in the field, and there weren't enough ideas out there that could be actionable and could be implemented and that we knew would be, evidence-based and work. And so we thought that we would set aside funding for this and create this innovation center that would test these new approaches to payment and delivery system reform in Medicare mostly, and then to a lesser extent in Medicaid. And the Innovation Center is given $10 billion every 10 years to invest in these new models. We want to find ways to improve quality and reduce costs. Hopefully our models do both, but if they do one or the other, we consider it a victory. And a model that meets the standards for improving quality or reducing costs can be expanded in duration and scope through rulemaking. So that's generally the idea. And, as you noted, we've focused on models on particular health conditions like end-stage renal disease, episodes of care like joint replacement, specific provider types like primary care providers, particular communities like rural health, and as well as innovation in Medicare Advantage and Medicare Part D. We have led over 50 models that have been in every state in the country. Between 2018 and 2020, almost 28 million Medicare and Medicaid beneficiaries and people with private insurance were impacted by or were receiving care from one of our models. So the ideas basically come from, I'd say, let's see, a lot of different sources. People bring us ideas. We get ideas. Some of the ideas were included in the legislation. Congress directed us to do some of the ideas. And then some are, areas of clear need and clear calling out for ideas and solutions. And I'd say the first 10 years of the Innovation Center, we threw a lot of spaghetti against the wall. Now I'd say we're trying to narrow down the focus of what we're concentrating on. So it's less about sort of everyone send us your good ideas and more about let's focus on what we think works and outline a clearer strategy.
Excellent. One can go to the CMMI website and take a look at sort of the history of the different models. There are those that are currently certified. There are those that are in current models under evaluation, and then some that were sort of deemed not acceptable. And I thought it'd be interesting just to go into one of each of these to go through sort of the scope of what you're involved in. And I thought a really interesting place to start would be with one of the certified models, namely the Medicare Diabetes Prevention Program, which is a really interesting one that's focused on behavioral change and interventions that not only deal with type 2 diabetes, which is I feel bad calling it as this a non-transmittable disease pandemic, but it is of that scale in terms of the direct and indirect cost of this thing are in the hundreds of billions. But it's one of those conditions where many organ systems involved, lifestyle issues, epigenetic component. And then a very interesting part of it all is that you're also looking on how you can prevent the transition from pre-diabetes, which again, in a huge area, from transitioning to type 2 diabetes. Can you just talk a little bit about how this program was developed and a little bit of what ultimately goes into after you do your magic and say, hey, this is worthwhile? What's involved in getting it certified?
Sure. So I'll talk first about the Medicare Diabetes Prevention Program, or MDPP. It was the second model to be eligible for expansion in 2016. And it started out, I mentioned that we threw a bunch of spaghetti at the wall early on. One of the ways that we did that was called the Healthcare Innovation Awards. And it was a couple rounds of $100 million of throwing out to a lot of different ideas. Come bring your ideas. It's not a lot of money, but hopefully seed money. And MDPP, I believe, was one of the models that came through there. And it built on a CDC National Diabetes Prevention Program that helps prevent the onset of type 2 diabetes among eligible at-risk Medicare beneficiaries. The model included over 6,000 participants. They underwent behavioral change interventions, including face-to-face counseling and group discussions. And that model generated a reduction in Medicare spending of $278 per beneficiary per quarter across 3 years. And so we were able to, based on these numbers, expand the test, and now it's available nationally. And I will say, this is the pros and the cons of the Innovation Center. I think a lot of interests out there would like to see it expanded to become a virtual program. Why do we have to go in person? We allowed that during the pandemic. Of course, you couldn't do in-person counseling for weight loss and behavioral changes. So we allowed virtual provision of care. But now that we're winding that down, the model that we tested is really the only one that can be expanded, and that's a face-to-face in-person model. And so it's, I think, maybe not had the reach and impact that it could. I think another maybe shortcoming is it hasn't reached populations of color to the greatest extent that it could, and it hasn't had the reach, I think, that it could. But that's the MDPP program, and it's an example of one that's been expanded.
And as far as the certification process, who exactly has to sign off? How does that work? Just so we have a little bit of an understanding of it.
Our actuaries, the CMS actuaries, have to certify with 95% certainty that the model is going to continue to generate savings on a net basis in future years. So on a net basis, in other words, if we're paying out for the model, it has to generate more savings that covers the cost, plus any savings to the Medicare program. And it sounds like an easy, like, oh, of course, but it's actually a pretty high bar, that 95% certainty, that sort of net basis. And we can talk about this in a moment, but some of the models that may be more impactful on a net basis aren't generating savings, even though the participants believe that they're generating savings. And so we end up in this situation where certification is such a high bar that the things that are certified aren't necessarily the things that have the biggest impact on the health system. And the things that aren't certified, I think there's been, some disappointment among some of the model participants that it's not able to go forward, and that, if a model's not generating savings, we need to shut them down. And we have done that when it can't get certified.
Got it. Thank you. One of the the models that is still under evaluation is entitled the Kidney Care Choices model. And here you're working specifically, which we would have this period of end-stage renal disease where the paths are either a dialysis, a kidney transplantation, an extremely expensive point in time, clinicians and caregivers. Not a lot currently, and at least my own experience in the pharmaceutical industry, in terms of being able to push back on that quite easily with drugs and so forth. What are some of the things that you're looking at? Obviously, this is still under evaluation, but what are some of the things you're looking at in terms of the incentives for the healthcare providers to improve the quality and delay the onset at this very crucial point in these patients' lives?
Well, Kidney Care Choices is the third of 3 kidney models that we have. We actually started with the Comprehensive ESRD Care, or CEC model, right, which looked at creating, improving care coordination by creating seamless care organizations, ESRD seamless care organizations, or ESCOs, that include dialysis providers, nephrologists, and other medical providers that tried to coordinate care for patients with kidney disease. Mm-hmm. And then we had the ESRD Treatment Choices, or ETC model, which aims to increase the rate of home dialysis and kidney transplants for beneficiaries with ESRD. And then the Kidney Care Choices, the one you mentioned, really builds off the CEC model and adds strong financial incentives for providers to manage the care of manage the care for Medicare beneficiaries with chronic kidney disease, and really delay the onset of dialysis. So moving further up the chain and up the stream of potentially preventing the onset of ESRD.
And moving to the third basket here, when you threw that spaghetti against the wall and some of the stuff hit the ground, any models that you specifically like to highlight or say these are extremely unacceptable? This spaghetti pile here, not to CMMI standards. And this can be therapeutic related. It could be, you're an expert in all these different payment models. And I noticed quite a few unique payment structure models that were part of the system. Highlight some things, if you would, that, you point out as, okay, we're never going to do that again.
Well, first, let me say that we have learned something from every model that we've put out in the field, whether or not it was deemed ultimately acceptable, or whether it was, ultimately ended at its natural end date. We have learned something and built on a lot of what we've learned that has helped inform future models, like with the kidney care models. I'd say models that sort of didn't quite make it to the finish line. I'll give you a couple of examples. One is the Most Favored Nations model. That the previous administration announced. I don't know if you followed, but the Most Favored Nation model would have tied Medicare drug pricing to the lowest cost in, I think it was 15 or 17 countries overseas. But it was nationwide, and it was a mandatory model, and it applied to about 70% of the drugs covered by Medicare. And of course, ended up in court. I think the drug manufacturers sued that it was exceeding our authority. It looked less like a model and more like we were trying to make policy change. And so when I came on board last year, we started the process to pull that model down. I think, no sense announcing something that's going to spend most of its time in court. I'd say another one that we also permanently canceled in April, that had been on hold since March of last year, was the geographic direct contracting model. And it was part of the global, it was related to the global and professional direct contracting model, but it was a part that would have required mandatory sort of ACO participation by region. So pick, 8 to 12 regions, and we're going to enroll everybody in that region in an ACO. It's an interesting approach, but I think it probably went too far. And there was a lot of concern. And frankly, and this was a lesson for us, the name is so familiar to direct contracting, a model that we're currently running that's generated a lot of potential concern for, is this privatizing Medicare? Are we enrolling people in private organizations? And we have updated the geographic, we have canceled the geographic direct contracting model and renamed, and we are transitioning the global and professional direct contracting model to ACO REACH at the end of this year. So, but I think that was a lesson in sort of naming, and also this, I think maybe the theme between the geographic model and most favored nation is that anytime you try to do something on a mandatory basis, you run into potential challenges just in terms of pushback and opposition.
Got it. Liz, one of the people that I had on a program about a year ago, well, maybe about a year and a half ago now, was Dr. Victor Zhao, head of the National Academy of Medicine. And one of the topics that we spent some time talking about was their $120 million longevity grand challenge, which had this primary focus in this area of health span, sort of broadly defined as this period of life that can be spent in good health, free of the chronic diseases and disabilities associated with aging. And this has become a really hot topic for the show, and there's been some economic analysis in the peer-reviewed literature that, if we could just shrink some of that period of time, it doesn't mean we're going to live to 500, but if we can shrink the period of time in life we get sick, we literally trillions of dollars potentially in terms of the benefits to society. I was just wondering if through the process of evaluating these models, whether you looking at diabetes, kidney care, so forth, all of them, have a pretty strong correlation to aging. Any interesting longevity, health span related stuff that you've seen come through the innovation funnel at CMMI?
Well, I don't know that I would say it's, dedicated to longevity, but I will say that as we've run a number of models that impact Medicare beneficiaries, we are really doubling down our focus on primary care. We've done some models in prevention, but really think if you look at countries where health outcomes are superior to the United States, and it's many of the developed nations, one distinct feature is that they invest in primary care, and that primary care is a bigger part of their health system. And so we have run 3 models, the comprehensive primary care model, CPC, and then we tried CPC Plus. Now we're running primary care first. And really that focus on screening and preventive care that can identify conditions earlier, that commitment to primary care, along with our ACO models that help manage chronic conditions and more, much more effectively than traditional fee-for-service, we really think that there's something to be said for and really increasing our investment in primary care. I'll also add that we have led a model called the Accountable Health Communities model that's focusing on health-related social needs of Medicare and Medicaid beneficiaries. So we look at screening, referral, and community navigation services to impact healthcare costs and reduce healthcare utilization. Really trying to demonstrate that if you address some of these social needs, which is moving even further up from before somebody gets sick or is in the, even before they seek primary care and preventive services, you might be able to make an impact. And I'll tell you, maybe even beyond that, another factor that has impacted the ability of some people to live their best and healthiest lives is, frankly, racism and the historical disparities that have impacted the health of populations of color. Less likely to be covered by insurance, more likely to be impacted by environmental factors that affect health, and disparities in treatment patterns. And so addressing health disparities by advancing health equity is another component of our new strategy that we announced last fall. And you'll start to see more innovation center models embedding equity into our work in terms of thinking about who participates, making sure that our innovation reaches all providers, including those that care for underserved populations. And that includes rural, so historically disadvantaged as well as rural populations, making sure that we're collecting data, including social determinants of health data. So all of those factors, I think the primary care combined with social determinants combined with other aspects of addressing health equity are maybe ways that we might suggest our approaches to address this health span concept that you outlined.
Excellent. Yeah, now the social determinants theme has been finding its way into every area we've been getting involved in. So no, that's exciting to hear you talk about that, and that it's a part of the innovation model. So that's exciting. One other thing, while we're on the topic of the National Academy, I noticed that you recently joined the National Academy of Medicine's Action Collaborative on Decarbonizing the United States health sector, and I found some fascinating numbers here in terms of health ecosystem representing about 8.5% of all the United States carbon emissions, and we have this chain from healthcare delivery, infrastructure, supply chain, once again everything impacted by the environment and the global warming situation. Say a few words, if you would, about the collaborative, how you got involved with it, and the importance of this theme in the general health ecosystem equation.
Sure. Well, last year it was the National Academy of Medicine, and they launched this Action Collaborative. It's a public-private partnership that includes leaders from across the health system who've all come together and committed to addressing the health sector's environmental impact and really thinking about how we can strengthen sustainability and resilience in the healthcare system. I mean, so many examples of where, including thinking about not just pandemics, but floods and other environmental factors and pollution and carbon emissions. So the collaborative really serves as a neutral platform for these participants to come around the table and think about collective goals and actions for decarbonization, looking particularly for evidence-based approaches and finding, really a shared commitment to improve health equity as well. You mentioned the 4 work streams. One is the supply chain and infrastructure, the healthcare delivery system, professional education and communication, and then the policy, financing, and metrics group. And I am co-chairing that with Don Berwick and Jonathan Perlin. Don Berwick asked if I would be interested, and it does sound interested, and I can't think of a more compelling issue than trying to address climate related issues. So if you go to the NAM website, you can find more information. They've got a list of more than 100 organizations that joined. There's records of some of their public meetings and also publications, but I think we're coming together to see where we can find agreement, and really pleased to be joining that group and under Dr. Zhao's leadership.
He's a great guy. I really enjoy talking with him about all these things.
That must have been an interesting conversation.
Absolutely. Listen, so in the beginning, you've consulted for presidents and heads of finance committees. You've worked at some of the largest pharmaceutical companies and healthcare insurers, think tanks. I love to ask a question about mentors over your career, because clearly you met a lot of fascinating people. Take a minute just to discuss, are there other people in this mix, obviously dealt with presidents and senators, but a few people that have really been instrumental to sort of keeping you on this journey, this goal of ultimately impacting our health ecosystem in a very positive way, controlling costs. Name some other folks that have been there with you along the way that have been really inspiring as you've been on this journey.
Yeah, that's an easy one. I know I have many people that I count as mentors who've helped me along the way. I mean, maybe starting with Karen Davis and Jerry Anderson at Johns Hopkins. Karen Davis was head of the health policy department, actually was head of the Commonwealth Fund for a number of years, but before I arrived, and really helped guide my career in thinking about covering the uninsured and some of the biggest challenges facing the healthcare system. And Jerry Anderson was my dissertation advisor. We're still in touch. He still sends ideas. He's one of the most thoughtful and prolific people in healthcare, and somebody that I have so much respect for, and who helped me get through through graduate school. And then a couple of, I would add, CMS administrators, including Gail Walensky, who was administrator in my of CMS, which was then HCFA, when I graduated from college. This was my first job. In fact, I'm now back at CMS, but my first desk that I had out of college is right down the hall from where I am sitting right now. And Gail really helped me think about, public health, public policy, which direction to go. And Nancy Andeparle is another who's been a guiding light for a lot of really important legislative and regulatory advancements in healthcare. She was administrator of CMS during the Clinton administration, and then in the White House guiding the Affordable Care Act. So I've known her for many, many years. And then I couldn't go without mentioning two of my bosses on Capitol Hill. You mentioned Max Baucus, and really learned so much from him about making sure you're hearing from all sides, and also making sure that you're able to explain what you're doing in a way that people can understand. And I don't know that I probably have much more to learn there, but he was really a master at what he did, and I enjoyed working for him very much. And Pete Stark,
Sure.
who was chair of the Ways and Means Health Subcommittee for many, many years, and I worked for him as well, and taught me the importance of really understanding healthcare and healthcare policy from a skeptical perspective. Like, don't always believe everyone who comes in and says, we're hurting, we need your money, we need your cash, we need this fix. And he, but also cared very deeply about the U.S. health system and making sure that we were on the right track. So I'd count them all among my mentors and guiding lights.
Got it. Perfect. Liz, one last thing. What's happening for the rest of 2022? Any other things that we should know about? We're going to obviously put the link to CMI website, your profile, conferences you're going to be speaking at, places we can watch you, meet you, somewhere in the public realm. Anything else you want to mention per the rest of this year, hot topics for early 2023? Please take the floor.
Yeah, well, thank you. And by the way, my door is always open, and my email's on the website, but I'll give it to you now. It's liz.fowler@cms.hhs.gov. We should be an open door. I really feel strongly, having spent so many years in the public sector, that we are at the behest of the taxpayers, and I'm here because I believe in public service. So want to make sure that people feel like they have a place where they can bring ideas and have conversations about things that aren't working, and hopefully that are. Love to hear that too. We are just now starting to travel. Hopefully we're not hit by another variant, but I haven't been attending too many meetings in person. So, email is probably the best way. We're also doing a number of listening sessions, really trying to be more open and transparent about the direction we're heading. So in addition to the strategy we put out in October, and a couple of blogs that we've published in terms of where we're going with ACOs. Our chief medical officer put out one on health equity. And so trying to give more indication of where we want to go in the future. And then the listening sessions, I think, are also a great way to tune in and find out what we're doing. The ones that we've had on safety net providers, on primary care, on how we capture the patient perspective in our models, and the beneficiary perspective, all of that's online. And please just watch the website and dial in, send us questions, send us your input, and we really want to hear from people.
Outstanding. It's you've been on a fascinating journey, Liz. I'm going to look forward to continuing to follow everything that you're doing and what's going on at CMMI. Really a neat story, and I'm glad you're, as I said at the beginning, I'm glad you're where you are doing this. For everybody that is going to be listening to this particular episode across the various podcast networks, or watching on the YouTube channel, you've been listening to Dr. Elizabeth Fowler, Deputy Administrator and Director, Center for Medicare and Medicaid Innovation, part of the United States Department of Health and Human Services, doing really amazing things to improve quality of care across these important programs, slowing the rate of growth in terms of their costs. Liz, I want to thank you again for taking the time out of your schedule to come talk to us. Thank you for everything you're doing there at CMMI. And as we like to say on this show, thanks for helping to create a better tomorrow for so many people via what you're doing. It's a really great story.
Thanks, Ira. I hope so. And thanks so much for having me. Really enjoyed the conversation, and hope to talk to you again soon.
We will do it again, definitely. Be well.
All right. Take care.